Great, wonderful. So once again, welcome on this board of medical MCQ for all. As you know, we are almost exclusively providing all study material, website, coaching, subscription, short package is also there where there is a money back guarantee if someone gets failed. So that is also there. Oman Viva coaching, full-fledged data flow services, mobile applications, dedicated mock test, and there are a lot more coming up with. So I will introduce with couple of new doctors as well. I myself, those who are new joining me first time, I'm hemato-oncologist and bone marrow transplant fellow, almost practicing for more than 20 years now, incorporated in Ahmedabad, India, Gujarat, and having a quite vast experience teaching and coaching many doctors on the various platforms globally. And I'm member of like active one of the US main body, American Society of Clinical Oncology. Right. So I would be happy to guide you throughout the journey. This is Dr. Aarti Motiani. So she is a wonderful lady, gold medalist for pediatrics. So this is very brilliant. She is with me for almost more than 5 years now. Dr. Maddie, many knows Maddie's as well. She is again internal medicine and brilliant speaker. Pallavi is coordinating with all, so you must be knowing Pallavi. She is support manager. Dr. Meghna is based at UAE. She is well trained from UK and with our company for more than 5 years now. She is now taking care of all data flows, exam booking, transfers of license, and whatever the logistics is there, right? She can able to handle from UAE. Dr. Sonal Shah is again a very renowned emergency physician in reputed hospital in Mumbai. So she is very regularly taking. And though these two young energetic lady, one is Dr. Pooja, who is also based at UAE, Dubai. She is the program coordinator for dental program. So we are probably by month end or this new year with new venture, we are starting the complete dental course for GP. And Dr. Akanksha Gosavi is recently joined. She is also popular name in coaching. So she is like started since last month. She gonna take a lot of lectures for internal medicine and all. So probably she will get into the class soon. And last but not the least, I don't have the picture, but another lady, the name is Dr. Kainat. She is like a program coordinator for homeopath as well. So we have two new feather in our basket is one is dental program complete exclusively and one is homeopath. So family, friends or anyone is interested in homeopath as well, just do let us know. So she probably join in sometime. These are our details. This is our one of the most popular book, right? We are revising it. So probably very soon we are coming up with the more new questions. It is revised already, but every 6 months, 8 months, 9 months we are making it. Data flow, as I told you, Dr. Meghna, me, and Pallavi, so you can contact anyone. And last but not the least, one of the most secret of success for any exam is our YouTube videos. Fortunately, it's a free access, right? So get the maximum advantage so far 170 plus. So even if you see this video, your 80% job is done. Believe me, because this is the same video now. By evening, it is 171, tomorrow 172. So it's keep updating the latest questions, high yield questions. So even if you see one video a day, it is, believe me, it is worth watching it, right? Whenever you are free, driving, going, coming home, absolutely important. So all subjects, not just the mock test, right? So a lot of subjects are there. And last but not the least, we have excellent mobile application on Android as well as iPhone. So these are the logo. This is for Android. This is for Apple. So those who are using it and don't know, they can download the mobile application. You can serve complete website from your mobile phone. And before we start and jump to our session, this is the key to success again after YouTube videos, right? Try to do maximum mock test, mock test, mock test, mock test, and try to do the assessment, self assessment. Every day, do the self assessment. Where are you standing? What's your score? Where you did the mistake? So, this mock tests are there for each and every subject on our website, right? So, you try to give the mock test. If not every day, obviously, twice a week, at least my by my experience, twice per week, at least do twice per week. So give two mock tests per week. So if you have 2 to 3 months of preparation, you end up with 12 to 15 good mock tests, and that covers almost 90% of your syllabus. It's all different shuffling mock tests. So it's available on the website. So you can go and see it. And as I told you, last but not the least, right? Dental we launch soon. Homeopathic we are launching soon. So both the program, and I'm also coach and co-founder of EMREE Prep as well. We launched last year in Dubai, so it's going well. So these are the two things. EMREE is already going on, but dental and homeopathy we are coming up with. And last but not the least, those right, those who are little many calls we are getting, especially me and my team. So just to make it more economical, this is the best package, 40 hours coaching. It's supposed to be 1000 USD close to. Now it is in the 350 only. So that is also very almost like a 60% plus discounted rate. So just inquire later on. So let's start and jump to the main stem. I want each and everyone to make your own score. You write down in your notes. You don't need to show me. You write down these questions I'm producing. Probably today we are like in next 1.5 hour I cover absolutely 50 questions with ease, with explanation, with interaction, with discussion. Though we discuss 10 questions, but I'll try to cover 50 questions, right? So your 50 question is done. And all high yield, all first time. Probably you listen first time, all MCQ first time. So it's very interesting and recently asked questions in the exam. So we and I formatted in that way. So whatever, say for example, you today I solve the 10 MCQ and your correct is 5, so your score is 50%. If your 7 out of 10 is correct, your score is 70%. So check your score. You don't need to show me, but see where you did mistake, what wasn't less than 4, 3, 4 score is not good, believe me. So you need to work hard on yourself and try to get help from the experts like us. So let's start without wasting the time. First questions in front of your screen. Ovarian tumor producing estrogen causing precocious puberty. What they are asking, understand well, this is question number one, right? So ovarian tumor, right? Ovarian tumor producing estrogen which causes precocious
Yes,
puberty. So
because yes,
ovarian tumor, is it dysgerminoma, is it Brunner's tumor, is it serous cyst adenoma, or it is granulosa cell tumor? Everybody must be knowing precocious puberty, but for bringing more clarity, what does it mean really? We need to know each and everything in the scenario. So, precocious puberty definition is appearance of secondary sex character before 8 years in a girls and before 9 years in a boy. That is a definition of precocious puberty. So now you have more clarity. Now they are asking which ovarian tumor producing estrogen causing precocious puberty. Dysgerminoma, Brunner's tumor, serous cyst adenoma, and granulosa tumor. Yes. If you shy, you can post your answer in the chat box. If you shy, that's fine. If you interact, I am very glad. If not, then at least post the answer and think each and every Q MCQ in this question comes in your exam. Think in that way that this will definitely come. Then you get the idea. I'm giving you 10 seconds. We are almost close to 20 doctors join. I can see only two posts. Just two posts or two answers in the chat box. Otherwise, I'll tell the name. Don't worry. I know all most of the doctors. Yes, Dr. Anisha, any comment from your side?
yes, it granulosa cell tumor.
Granulosa cell tumor. Okay, fine. Why did you select it? That we'll discuss later on. Let me check with one. Dr. Tilotama, what is your answer? I mean, what do you think what it could be? I'm coming to you, Dr. Anisha. Don't worry. We are not in hurry. We need to understand each and everything. Yes, Dr. Tilotama, you can unmute your mic. You can ask. You can discuss. Yes, Dr. Savita, any comment?
Yes, sir.
Yes, sure.
It looks like granulosa cell tumor, sir.
Okay, so
Generally, in
how
this case, because of estrogen, the early breast development and vaginal bleeding will be there, which causes precocious puberty.
wonderful, brilliant. So I think you are gynecologist. Brilliant. So what happens in dysgerminoma? Can you little bit describe what is dysgerminoma? How you define the Brunner's tumor? What is serous cyst adenoma? Can you little throw the lights on this? What is Brenner's tumor? They may ask you something related with Brenner tumor. So if you have idea, I'm fine. Answer is granulosa cell tumor. Perfect. So those who did not given the right answer, make your score one question asked. If wrong, score is zero. If you answer correct, one out of one. Check your score later on. End of my class. Fun, wonderful. So let me give you the bit detail insight. We dissect each and every MCQ. Our job. This is your job, right? Everyone's job, not just to get the answer, but you need to exclude why not this, why not this, why not this. This is real learning. Otherwise, you won't get the
Sir,
real depth of knowledge. Yes. Yes,
uh,
you go ahead, doctor. I'm
Brenner's
listening.
Brenner's tumor, I remember I think it is a epithelial cell tumor, sir, and
Okay.
it's seen mostly in postmenopausal women.
Okay. Fine. Fair enough. So from where it arises? I mean, from
From the
epithelial cells of the
epithelium,
ovary. Okay. Fine. Fair.
ovarian epithelium, ovary.
Wonderful, fair enough. So everyone's go and read it all four topics. Those who are like little blank, what is this germinoma? Go and read it. What is Brenner? Go and read it. What is serous cystadenoma? This is not difficult questions. Commonly asked question and granulosa cell tumor. So you need to know little histology of the ovary. So the answer is a granulosa cell tumor. Granulosa cell tumor are the sex cord stromal ovarian tumors that secretes the estrogen. That secretes the estrogen. This is the one of the most high yield point. Granulosa cell tumor secretes the estrogen, and due to excess of estrogen, it can cause the precocious puberty in young girls, endometrial hyperplasia, postmenopausal bleeding in the older woman, right? So this is what the thing is, right? So granulosa cell tumor produces or secrete the estrogen, and this excessive estrogen can cause the precocious puberty. These are the symptoms. How do they present in the clinical practice, right? Other options, like we have four options. So one is granulosa cell tumor is the D option, so that is correct. Now first one is dysgerminoma. What happens in dysgerminoma? LDH is elevated, not the estrogen. See the beauty. LDH is, so wherever the estrogen is elevated, at that time you can see the precocious puberty, and that is secreted by the granulosa. That is why answer. Brenner's tumor usually benign may produce androgen, not the estrogen. Androgen, not the estrogen. Right? This is because of estrogen. Serous cystadenoma, epithelial tumor, as she is rightly said, non-functional, right? So probably not producing anything. So this is the things. Now let's dissect little bit more in detail. So dysgerminoma, why not? So our answer is D, right? Our answer is granulosa cell tumor. But we need to see why not A, why not B, why not C. So let's dissect that part as well. So dysgerminoma, why not? That is very important. Dysgerminoma is a germ cell tumor, or GCT, does not produce estrogen, and that is why it is not causing the precocious puberty. It produces the LDH, most common marker. So second question in exam, dysgerminoma,
इधर
which
भी
of the
वो
following
बना रहे हैं
tumor marker is produced? So which of the following tumor marker is produced? That is LDH, right? So they may give you beta HCG, LDH, estrogen. What's the answer? Answer is LDH. What is germinoma? Right? Rarely HCG, right? And clinical features, how do they present dysgerminoma? It's a abdominal pain, abdominal mass, rapid growing, but it does not producing precocious puberty. Why? Because it does not produces the estrogen. Our question is estrogen producing, causing the precocious. So it is very clear cut now. Let's move to the another Branner, right? We need to know each and every, as we discussed, we need to exclude each and every option for every MCQ every day. This is what the practice you need to do. Brenner's tumor, why not? Brenner's tumor is benign epithelial ovarian tumor, usually non-functional, means no hormone producing, right? Occasionally producing the androgen, not the estrogen. And because of this excess androgen, it can cause hirsutism and virilization, not estrogen secreting tumor, so cannot produce the precocious puberty, and produces the androgen, not the estrogen, and that is why it is not the answer. And last but not the least, the thing is serous cyst adenoma. Why not? Serous cyst adenoma is benign epithelial tumor, does not secrete any hormone, right, including estrogen, completely non-functional tumor, no estrogen, no precocious puberty, no hormone activity, not the answer. So concluding my talk here, this is a beautiful picture I got it for you guys. So if you remember or take a picture of one slide only, it concludes everything, right? Summary is what? Dysgerminoma, it is as I told you, LDH mod, very rarely it secretes or produce HCG, human chorionic gonadotropin, no estrogen, can cause puberty? No. Why not? Because it is not estrogenic or not producing estrogen. Brannard's tumors, sometimes androgen, right? Androgen it produce can cause precocious puberty. No. Why? Because it's androgenic, not estrogenic. Serous cyst adenoma, it is non-functional, not producing any hormone. No estrogen means no precocious puberty. So, granulosa cell tumor produces estrogen, can cause precocious puberty. Why? Because excess estrogen can cause all the things. So, that's all from my side. Concluding the first questions, I think I'm pretty much clear from my side, right? To explain you guys why it is this and why it is not that. Right, so you need to go little bit in detail. I mean, we are not going to give the GYNEC exam, but you need to know also you need to know the ovarian cancer. So we have a lot of questions to discuss anyway, right? So we'll discuss everything. So ovarian cancer, ovary cancer, you need to know how you diagnose the ovary cancer, how you investigate, and how you treat. So those who are joining me first time, it is a popular triad by me. This triad includes so any MCQ multiple choice questions from today onward, right? Ask yourself what is a diagnosis, ask yourself how you gonna investigate, ask yourself how you supposed to treat. So if you become a master of these three questions, asking yourself, 99% chance that whatever they ask in your exam, I can challenge and guarantee you everybody's pass. Believe me, take me in writing. But you need to do the practice, right? Not just the listening and joining the next Sunday. You need to do hard work like the way I'm doing it every Sunday for you guys to explain more. So let's jump to the second questions. Your score mentioned one on zero. A 22-year-old male present with a peri-umbilical pain migrates to the right iliac fossa, anorexia, low-grade fever. On examination, MAC Burney tenderness positive, WBCs of 14,000 per cubic millimeter. USG shows non-compressible tubular structure in right iliac fossa. Best treatment is IV antibiotic and discharge, delayed elective appendectomy, immediate appendectomy, laparotomy. So think over it. Again, the three things will come in your should come in your mind in every MCQ. What is the diagnosis? What is the investigation or what is the treatment? What they are asking is directly the management or probably the treatment part. So you need to think these two things, right? You is it there in the scenario? So you find and check it out. What is the diagnosis? How they investigated, and now they are jumping on the treatment part or management part, right? So we see the earlier was gynec question. This is surgical question. We have all different specialty of questions. So I'm not biased by one subjects, right? So everybody will check their own knowledge in all field. Yes, so you take your time, 10-15 seconds, post your answer here. What's the diagnosis? How you gonna do it? What you want to do it? How you want? Yes, Dr. Sonia. So let me start with you if you don't mind. What do you think? What is the diagnosis? First, tell me the diagnosis. Will not break this chain. Yes, Dr. Sonia.
So it looks like an uncomplicated appendicitis. So the
I'm
immediate
writing down uncomplicated just for learning because we are more than 30-40 doctors. So it's a learning platform. Uncomplicated appendicitis, right? That is what you think. Fair enough. Wonderful. Brilliant. So now can you tell me on what ground you thought that this is uncomplicated appendicitis and what is complicated appendicitis? Yes, please tell me.
because McBurney's tenderness is positive, which is a sign of appendicitis.
Okay, McBurney is right because whenever you answer any questions, right? Tips. This is tips, right? So you need to check whether this sign, symptoms, features, USG, radiology, microbiology is there, fitting there or not. Yes. So McBurney's tenderness. Okay, fine. It is there. McBurney's tenderness is positive. Okay, fine. One thing. This is the only one thing, or is there any other
And
things?
the WBC is 14,000. So that means there is inflammation also.
Inflammation. So
And not
WBC is 40,000. Wonderful. What else?
and And uncomplicated because they haven't mentioned any perforation or any
Wonderful, brilliant. So
peritonitis.
vitals are stable. Not mentioned means it is stable. Vitals are
Yes,
normal or stable. So likely uncomplicated, right? Or
yes, sir.
no perforation,
And
no guarding, no rigidity, nothing they mention means it is okay. When something is not mentioned in the exam means normal, considered in that way. Fair enough.
and sir,
Platelet here not mentioned, so platelet normal. Go ahead, please.
and the other features, the clinical feature they mentioned, anorexia and low grade fever
Wonderful. So
also.
sign and symptoms. So let me now dissect this question. Appendicitis is usually seen in young. See, there are 10 points in the just 3 lines. Check each and everything matching. So age is extremely important. Age is extremely important. Male commonly. Second thing, periumbilical pain. Think of appendicitis. Migrating to right iliac fossa. That is also classical. Fourth, anorexia, low grade fever 5, McBurney's tenderness 6, leukocytosis 7, and tremendous classical features of acute appendicitis. When you do the ultrasonography of abdomen, it shows non-compressible tubular structure in right iliac fossa. So see, there are 8 points which favoring the uncomplicated appendicitis, right? So our mind is clear cut. So you need to dissect all the points in every MCQ, right? If you say this is acute cholecystitis example, so you need to match why it is acute 1 2 3 4 5 6. You have to, everything is there in the scenario. If you cultivate and keep some patience reading the MCQs well, believe me, 90% of the job is done for the correct answer. Wonderful. So this is one thing. So you make a diagnosis very nicely, doctor. Now tell me, right, you investigated as well, right? So count CBC showing high count, there is a compressible tubular structure. So what is the treatment? What is the treatment? Why you don't want to do the laparotomy? Why you don't want to do, right? I mean, patient is non-complicated, so why you are in hurry? Why you don't want to delay elective appendectomy? No, patient is not in emergency, he is not in shock, patient is fine, right? So why you want to do the immediate appendectomy? What is the reason? Even you can give the patient antibiotic and then you can see the response in 48 hours. If counts are 8,000, right, patient pain is gone, right? Why you don't want to give the antibiotic and discharge the patients? Let's start discussion. Yes, Sonia. Why I'm raising these questions to open and activate your everyone's mind, right? It's not just monotonously we are doing the MCQs. Yes, Dr. Sonia, you go ahead. I will ask a lot of
So,
questions. You can explain as per your knowledge. Yes, please.
so I think laparotomy is done if there is any sign of perforated appendix or any
Wonderful,
other signs
brilliant,
along with this
wonderful. So
abscess.
it is gone. It is gone.
Yes,
Wonderful, brilliant explanation. So it is not a emergency, no shock, no perforation, no peritonitis, nothing, right?
yes.
Wonderful. Then why not this later on? Why not the IV antibiotic? I mean, patient is fine, na? Young boy, you can wait and watch. What is the disadvantage, or why you don't want to give the antibiotic and wait for patient for improvement and discharge? Anyone else wants to comment? It's fine, right? Those who are active, I'm asking them, but it's open platform. We are now 35 doctors, I can see. Anyone can answer. Yes, Dr. Akanksha, welcome.
Good
Uh,
afternoon, sir.
Very good afternoon. Yeah, so let me break it out these questions for you. So first of all, let's see the answer. Real immediate appendectomy, right? So immediate appendectomy is why immediate appendectomy clinical reason. As I told you, we need to see and check each and every what point favoring your diagnosis. So this is all favoring classical acute appendicitis or uncomplicated, non-complicated, right? Periumbilical pain migrate to right iliac fossa. Why typical visceral, right, pain pattern, parietal pain pattern, McBurney's tenderness, strong clinical signs of appendix, strong clinical sign, and they are mentioning it is positive. So it is a one of the strong. There is acute inflammation, right? The white cell count is increased. So our thing is our scenario is this, our scenario is this, our scenario is this as well. And last but not the least, ultrasound non-compressible tubular structure. This is a key USG finding of inflamed appendix. So this is very, very important, right? So it's extremely so. Therefore, the best management urgent appendectomy. So let me tell you, whenever uncomplicated or complicated, right, you need to open up. Surgical treatment is one of the most important treatment for appendicitis, acute appendicitis. right? Why not the other options? Let's dissect, then we bring more clarity to in our mind why not IV antibiotic and discharge this patient. Antibiotic alone are not standard for uncomplicated appendicitis. High failure rate and risk of perforation. If does not work, it a high risk that they end up with a perforation and then emergency laparotomy, right? Only used in selected patients where you cannot undergo surgery. 10% cardiac pumping, ejection fraction is 10%, multiple comorbidity, high risk, or some other obvious contraindication like platelet counts are 15,000, underlying ITP and acute appendicitis. There are long list of contraindication, but in general, only used in a selected patients where surgery cannot be done or performed. In that case, you think of conservative. Otherwise, number one treatment globally accepted is a appendectomy, right? So this is the second option, not the first option, right? So delayed elective appendectomy, why not? Why you don't want to wait and do delay and give antibiotic and then after few days, 5 days, you don't, right? There is no role for interval appendectomy in uncomplicated case. This is uncomplicated case. Interval appendectomy is done only for appendicular mass, not the appendicitis. So patient first time present with the appendicular mass, right? Phlegmon or manage conservatively, right? So in that case you can do the this thing elective, but elective is not required in most of the patient, right? And last but not the least, laparotomy. Laparotomy is completely opening the abdomen from the xiphisternum to the umbilicus or maybe below, depend on the condition. So completely vertical incision, you open up the complete abdominal or anti-abdominal wall. Laparotomy is not needed for simple appendicitis. This is not a complicated, this is a uncomplicated appendicitis. So laparotomy is not needed for the simple appendicitis. Laparoscopic appendectomy is preferred if available. If available, laparoscopic. So there are two ways, right? So this is tummy, this is a cecum, and below here is a appendix, right? So you can remove appendix, right? By opening, make some small incision here, right? And you can remove the open, or you can enter the laparoscope. Laparoscope little less invasive than open. So laparoscopy, right? So if it is there in the options, so laparoscopic appendectomy is preferred if available. But if not, then you can do it open, right? Open means like you don't need to do it. What is laparotomy? This is umbilicus. This is a sternum, right? This is xiphisternum. So you do the complete here. This is completely laparotomy, right? This is laparotomy. We don't need to do the laparotomy, open up the whole abdomen until and unless complicated, perforated, sign of shock or septicemia, or they have peritonitis where you don't know where is the perforation, and in emergency sometimes patient is in shock. You may not able to do even well this sonography or CT scan not available. Patient is absolutely in real emergency with systolic blood pressure. In that case, you need to open up. You don't know it is what perforated, gallbladder perforated, appendix perforated, colon perforated, peptic ulcer perforated. Laparotomy is the answer, right? Because you need to see a lot of things, right? So here the open appendectomy, right? So laparotomy is the wrong answer for this uncomplicated appendicitis. So you just open it, right? Preferably laparoscopy, if not then small scar and you do the surgery. So in context to our questions, our answer is appendectomy as soon as possible. Patient is symptomatic, patient has a signs of inflammations, appendicitis, classical case, right? Make the patient's NBM, take the consent, do the IV fluid, ABC, start as soon as possible to prevent the complication. Now it's uncomplicated, but if you don't do it, it will perforate. That's it. So you need to do as soon as possible. So treatment of choice is immediate appendectomy, preferably laparoscopic. If not, then open. That's it. So let's jump to the next question, third question. So your score would be either three category so far, right? So somebody has 2 out of 0, somebody has 2 out of 1. Brilliant people have 2 out of 2. So check your own score. Check your own score, right? So let's jump to the third questions. A 60 years old male with septic shock. Scenarios are little interesting and and with the lab as well, because never expect one liner question in exam. Same thing will come by and large. A 60 years old male with septic shock develops bleeding from venipuncture site. Lab showing platelet counts are 40,000 per cubic millimeter. PT means prothrombin time is prolonged. APTT means activated partial thromboplastin time is prolonged. Fibrinogen level is low. or very low, D dimer is very high. Now they are asking directly the management. So we don't know the diagnosis here. We don't know the diagnosis. So we need to make a diagnosis. How we supposed to make the diagnosis? By knowing our clinical triad. Simple. What is the diagnosis? So if you know the diagnosis of this scenario, your job for the management or treatment would be much easier. So first we need to make the diagnosis, which is not given here. So platelet means CBC means hemoglobin and total count is not given. So we considered it normal. PT is prolonged, APTT is prolonged, fibrinogen is low, D dimer is high. So what is the diagnosis? Number one question. Then jump to the management. What is the best management? Are you gonna give this heparin infusion to this patient? Are you going to start the aspirin for this patient? Are you going to treat underlying sepsis, give FFP and cryo, or you just give the platelet transfusion only? Otherwise, patient is fine. They are not mentioning vitals. That is why we considered the vitals are stable. Patient is normal vitals, but this is the condition, right? So you had taken the blood sample from the cubital or upper limb, and what they found is 60 years old male with septic shock. So this is one diagnosis, provisional diagnosis is septic shock, right? Just a clue to you, right? And they develop the bleeding from the venipuncture sites, right? So when they are trying to collect the blood from the veins for the CBC, LFT, RFT, all this electrolyte, PT, PTT, fibrinogen, they found there is something bleeding from the venipuncture site, right? Probably because of platelet, probably because of platelets are 40,000, right? So what is the normal platelet count is 150 to 450,000, right? And here it's just 40,000, 40,000. Normal is this, just for your knowledge, right? So this is the scenario, how you manage this patient now. What is the diagnosis? What makes the diagnosis favored in this scenario? Yes, anyone? I'm first interested in the diagnosis, then answer.
DIC.
Sorry, sir.
Disseminated intracoagulation, DIC.
Wonderful. Sorry, I'm seeing your name as a iPhone. So what's your good name? Sorry.
Dr. Shama.
Dr. Sama. Wonderful. Brilliant. Thank you very much. Now tell me point favoring the DIC. What do you exactly mean by the DIC, Dr. Sama? Yes, tell me. How did you get thought process of DIC in this? What point favoring the DIC? I'm just saying the septicemia, not the DIC. I'm thinking that this is septicemic shock. This patient has a septicemic shock, not the DIC. How we differentiate? That okay, differentiating point. Head to head differentiating between septicemic shock and CDIC.
Not
the DIC. How we yes. I'm saying answer is septicemic shock. You are saying DIC. Head to head differentiating between septic. Sorry, one by one. Sorry, septicemic shock. You are saying for me to understand.
So in DIC, activation of the intravascular coagulation.
Sorry,
Hello.
let the Dr. Sama to finish, then we'll discuss. 1 minute, 1 minute. Sir.
Activation
Yes,
of the intravascular coagulation.
Let the Dr. Sama to finish. Yes, sir. Yes, doctor.
Yeah, so platelet count will be decreased and the
Yes, sir.
PN platelet count will be decreased and the PN increase.
Okay. So DIC platelet count is decreased. I am also saying that platelet count is also decreased in septicemic shock. Okay.
Yeah, but
Now I'm also
I think sir D dimer is increased due to the fibrinolysis. So
fair enough. So D-dimer, do the head-to-head comparison. Platelet counts, what happen in DIC, platelet count, what happens in septicemia. So I had given you in a severe septicemia, you may have low platelet count. In DIC, you may have low platelet count. What else, right? How you differentiate? Because both the things are reduced in both the condition.
okay. Yes, sir.
You understand what I'm trying to explain,
Yes, sir.
right? So is there any other point which like differentiate between DIC and septicemic shock? Because still we are struggling for to get the diagnosis, whether it is this picture is because of DIC or this picture is because of shock or septicemic shock. Now you explain. Now you give the complete clarity, bring the clarity, will help you a lot of things in clinical practice. My lecture will help you in clinical practice as well. not just the cracking exam. It's an important day-to-day job. Anyone wants to try now? Somebody was telling on the background, right? Open up. Anyone wants to comment on? My my discussion is that platelet count is reduced in both the things. How you differentiate between DIC and septic shock? Question is simple. Answer is also simple, but I think you guys are confused or afraid. Yes, anyone? No one has done the duty in ICU. Nobody has seen the septic shock. Nobody
Sir,
has seen the DIC. Yes,
sir, due to sepsis, there will be massive inflammatory response, sir.
wonderful. So you are thinking that because of massive sepsis, right? Sepsis or
Yes, sir.
septicemic shock is a predisposing factor to DIC, right?
Yes, sir. Yes, sir.
Wonderful. Now, how you
Septic
differentiate? The
sepsis
same
is
question. How
dangerous.
you differentiate?
Sir, due to sepsis, DIC develops, and in DIC, there will be bleeding from the sites of venipuncture sites, sir.
Okay, so bleeding is there in
In
DIC. I'll write down here, which is
Yes, sir.
probably less likely in septic shock. Probably less likely in septic shock
Yes,
because platelets are low in both the condition. So it is there,
yes,
plus or minus. Usually we are not saying, but it could be. Fair enough. What else?
yes, sir.
What else? This is the only two things. What happens to PT here? What happens to PTT here? What happens to fibrinogen here? And what happens to D dimer here in DIC as well as in the septic shock? So let me tell you, right? So go and read it in detail later on, right? So when there is a first thing is a infection, means systemic inflammatory response, SIRS. You must have seen, right? Right? When this infection, right, is documented by blood culture positive, it is called septicemia. If your tonsillitis, it is not septicemia, but tonsillitis, blood culture is positive, it is septicemia due to tonsillitis. So blood culture positive here, blood culture and sensitivity or blood culture is positive. This is septicemia. Blood culture positive is septicemia. When blood culture positive with hypotension, low blood pressure, it is called as a septicemic shock. See the little minor difference. So septicemia with normal blood pressure is not septicemic shock. Septicemia with low blood pressure is septicemic shock. And definition of shock is anything less than 90 systolic blood pressure in any patient in general. Anaphylactic shock, septic shock, cardiogenic shock, hypovolemic shock, or neurogenic shock. These are the major 5-6 shock, right? In all, the primary definition of shock is less than 90 systolic blood pressure. So if septicemia patient has 120 systolic blood pressure, he is not shocked. Just the septicemia. Patient has pneumonia, vitals are stable, blood culture showing staphylococcus or streptococcus aureus, it is septicemia, but not shock. BP is normal, urine output is normal. When pneumonia patient develops 70 systolic blood pressure, it is septicemic shock secondary to pneumonia. Are you getting me? Yes or no?
Yes, sir.
And this eventually developed the lots of disseminated. This sepsis is generalized. Now your bacteria, your blood, your organism is in the blood and blood flowing throughout the body, so it is disseminated, and this cause eventually disseminated intravascular within vessel coagulation, right? So it is called consumptive coagulopathy. So there is a clot. So when there is a clot form, right? My primary area of interest is hematology for many years, as you know. So we'll learn sometimes when clot forms, you need what you need in clot form. One, you need a platelet. Without platelet, platelet will not form. You need fibrinogen to clot, right? You need factors to clot, clotting factors to. So all will consumed in the clot. So in DIC, there is a lot of coagulation. So because of platelet consumption, platelet counts are low. Because of fibrinogen consumption in the clot formation, fibrinogens are low. And factor 7, factor 8, factor 9, 10, 11, 12, we'll see in the clotting cascade very brilliantly. I'll explain you. So this factor will also consumed, means factors are also low in plasma, but when factors are low, PT and APTT will rise. PT and APTT will rise, right? But if you do the factor level, factor 8 level, reduce. Factor 9 level, reduce. But PT, APTT rise. So this is classical. Platelet is reduced, yes, because of the consumption. Prothrombin time and PT increase, yes. Why it is increased? Because factors are also. So consider this is a clot. Consider this is a clot. Consider this is clot. So in clot, you consume platelet, you consume fibrinogen, you consume factor. So platelet low, fibrinogen low, factor low, and factor effect on PTA, right? So it is increased. Like hemophilia factor 8 is low. How patient present increase APTT. That's it. So here the same thing. So platelet low, PTA, high, fibrinogen low, and there is a D dimer. D dimer is non-specific in general, but it increases because of fibrinolysis. She told, right? So this is what the thing is. So now you get to know that this patient, which is usually absent here, right? So how you exactly? So what happened? In septicemic shock, there is no clot. There is no clot in the septicemic shock, right? So because of septicemia, there is a bone marrow suppression. So platelet may go down, right? D dimer because of infection would be high, right? But PT and APTTs are normal in septicemic shock. Normal in septicemic shock, because in septicemic shock, like DIC, clot is not formed. Clot is not formed, and that is why the factor is not these things, right? Even fibrinogen is less likely decrease, but still PT and APTT is not affected, and that is why it is normal. So whenever any septicemic patient comes to you, you need to find out where is the infection source: chest, oral cavity, lung, urine or stool, or GI tract. Number one, you need to see the vitals. What is the vitals? What happens to this? Is the blood culture is positive or negative, or is it real sepsis, or it is DIC? In that case, especially the bleeding patient, you need to see the PT, APTT, fibrinogen. These are the primary, right, screening clotting factors. So any patient comes to me with a bleeding, I will see two things. The bleeding is because of two things. It is a hematology class, but anyway, just primary right? Primary is a platelet, and secondary is a factor. Secondary is a factor. So first get platelet. So if there is a problem, right, in the platelet, thrombocytopenia or platelet functions disorder, you have bleeding of platelet type. And when there is a problem, platelets are normal, but problem like hemophilia A factor 8, hemophilia B factor 9, hemophilia C factor 11. So such kind of problem where you get a little delayed bleeding, in deep bleeding, muscular bleeding, cranial bleeding, we'll see sometimes in this, right? So this is more bleeding problem happens in the DIC, not in the shock. And PT and APTT is usually the normal in the septicemic shock, for your kind knowledge. So this is how you can also differentiate in your clinic or in ICU or in the practice anyway. So now we have bring more clarity to this MCQ. Now let's discuss what is the treatment now. So we have things that, okay, this is DIC, sir. Now I want to treat the patient. So what is the treatment of DIC? Forget about the option, but how you supposed to manage? Or let's discuss about these patients only. How you supposed to manage this patient? You have 4 options. Are you going to give heparin? How many people in favor of heparin? Tell me yes. Yes, please. Anyone? Now we are 37 in the group. I need only 3 good answers. Yes, Dr. Savita, let's you talk.
Sir,
Why and how you want to manage this patient?
sir, first of all, she is having septic shock. Maybe
Okay,
I'm
yes,
wrong, sir,
septic
but
shock.
I would just
No,
try
no,
to.
nobody is wrong.
Uh,
You go on.
uh, so
Discussion is important.
I would like to take treating sepsis also very important. Treat
Wonderful. So
underlying sepsis
wonderful. So you
plus.
treated one part, treating underlying
Mm,
sepsis, right? So
mm,
whatever the organism and culture and sensitivity, you treat accordingly. So basically, treating sepsis is basically antibiotic. Obviously, patient is in shock, so ABC is also there: airway, breathing, circulation, stabilization, sending the lab. That is routine job. But now treatment is ABC stabilize, right? Antibiotic. So treat underlying sepsis, right? You
mm.
did it. Wonderful. What else you want to do for this patient?
Then we need to treat her DIC.
Wonderful. So this patient has a DIC. Brilliant. So DIC, you need to treat the antibiotic, the septicemia part, also immediately the DIC part. So how you gonna treat this DIC part in this patient?
Platelet infusion.
Wonderful. So platelet transfusion. or PRC or pack red cell, platelet rich concentrate, or sometimes you can use the SDP, single donor platelet. So simpler layman language, platelet support or platelet transfusion is required. Fine, fair enough. Number one. Reason is patient is bleeding. Yes, patient is bleeding. Reason two,
And
patient's platelet
platelets
counts are
is
low,
less than
40,000. It's symptomatic thrombocytopenia. What is asymptomatic thrombocytopenia? You have 50,000 platelet count, but no bleeding. Say, for example, ITP, 50,000, no platelet. Patient has a 50,000 platelet with bleeding. So it's a difference. So it is called symptomatic thrombocytopenia. This is asymptomatic thrombocytopenia. So this patient has a symptomatic thrombocytopenia. You must treat it. You must address it. Wonderful. So you treat antibiotic, you did a platelet transfusion. What else you want to do for this patient? Is your job is over, or you still want to do something more for this patient who is in shock, who is bleeding?
Yes, sir.
Inotropic support.
We need to give her cryoprecipitate
no
for
plasma
the
transfusion.
Ice frozen plasma.
Okay. Cryoprecipitate. So now tell me what contains in the cryoprecipitate. What
The
is there in the
fibrinogen,
cryoprecipitate?
fibrinogen,
Oh, wonderful,
fibrinogen.
brilliant. Fibrinogen is there in the cryoprecipitate. What else? Because we are ordering the ICU every day. This is my day-to-day job now. Our patient leukemia, lymphoma, myeloma, they
Sir,
commonly present with DIC shock. Yes.
frozen plasma transfusion. Sir,
Okay. No,
plasma
but I want
transfusion
to know.
because prolonged.
Yes, plasma transfusion is correct answer. FFP, fresh frozen plasma. But I want to know. My question is still not. I got the proper answer. Cryoprecipitate contains what? Only fibrinogen, 100% fibrinogen, or something else is there in the cryoprecipitate as well? That is what my question is. I want to know.
Factor 8
Factor 10.
and factor 8 and 12.
Yes, yes. Tell. Go ahead. Whatever you know.
Factor 8 and 13, sir.
Factor 8 and factor 13. Okay, fine. So let me tell you, you can write down. You can write down or remember at least. Number one, most important thing is fibrinogen. Cryoprecipitate contains, write down. Number one, cryoprecipitate contain. Number one is a fibrinogen. Our patient has low fibrinogen, so we need to increase cryoprecipitate. Helps. Simple. Second is factor 8. Factor 8 is again a major factor in clotting, right? PT and APTT is increased, so probably factor is also consumed. So factor 8 is one of them. So factor 8 is there. Third thing important, just for your kind knowledge, von Willebrand factor. Von Willebrand factor. Nobody told me about this. This is fourth thing. Third thing, sorry. Factor 13, clot stabilizing factor. Clot stabilizing factor. This is right. So this is four things are present in the cryoprecipitate. Somebody asks, what is there in the cryoprecipitate? Fibrinogen, factor 8, von Willebrand factor. Again, treatment of von Willebrand factor or von Willebrand disease is to give the cryoprecipitate. Cryoprecipitate. Why cryoprecipitate in von Willebrand disease? Because it contains von Willebrand factor, right? Or antigen. In von Willebrand disease, there is an absence or mutation in the von Willebrand factor, and that is why patient present with the bleeding, and to stop the bleeding you need to give this, right? One treatment you must have read is desmopressin. Have you heard of this? Yes or no? Desmopressin. In a mild category you use the desmopressin. Second is you transfuse directly the von Willebrand factor, and how you transfuse is by cryoprecipitate. Is that clear to everyone? Yes or no? Yes or no?
Yes.
Yes, sir.
Yes.
Nice. At least yes or
So
no.
can you explain once more the thing about desmopressin, sir?
Desmopressin is basically, we'll cover in hematology, don't worry. So von Willebrand disease is basically because of von Willebrand factor. So to clot the blood, you need lot of things. One is platelet. Next time, drop me directly the query what point and subjects you want to learn, especially in hematology from me. I'm super expert, not praising myself. I'm into it for more than 20 years. So I'll try to clarify the concept, not mug up concept. So when you have clot, you have platelet, you have factor. Fibrinogen is one of them. Factor 8, 9, 10 fibrinogen, right? And plus one Willebrand factor. If you have low platelet thrombocytopenia, you have bleeding. If you have hemophilia, factor 8 deficiency, hemophilia B, hemophilia C, factor deficiency or hemophilia, you have bleeding. Here you have bleeding. Here you have bleeding. Right? You have both the things said very well, but factor von Willebrand factor is absent. The name of the disease is von Willebrand disease. You have bleeding. So how did you get to know the bleeding is because of what? So that is why we need to do CBC, and in CBC, which contains platelet count, you need to do PT, PTT, and fibrinogen, which talks about the factor. And if you are thinking this patient childhood inherited early childhood early menarche, right, or since first menarche she has a bleeding, right, then it is a clue for the excessive menses since beginning, von Willebrand factor. So when you are thinking von Willebrand factor, you need to ask for the serum von Willebrand factor antigen activity when you are suspecting, right? Because these three can cause bleeding, right? So what happens if absent? This is the endothelium. In endothelium, this is vessel and this is endothelium. So in within the endothelium, von Willebrand factor is there. What releases this von Willebrand factor is desmopressin. So when you give the desmopressin, it increases the secretion of von Willebrand factor from endothelium to plasma. It will increase, it stop the bleeding, and that is why it is a treatment in von Willebrand disease. Is that clear? I'm trying to make it simplified. Dr. Sonia, is that clear?
Yes,
Yes,
sir.
sir.
Yes.
Yes, sir.
Wonderful. And when you have no response, like severe, right? Severe von Willebrand disease, right? There are three types: type 1, type 2, type 3, right? So we will see sometimes type 1 is deficiency, here mutation, and here severe deficiency or absence. This is worst one. One is 90% of the patient have type 1, which is easier one, which is mild, right? So we'll see it. So von Willebrand disease treatment is desmopressin plus you can give the von Willebrand factor antigen, or you can give the cryoprecipitate. Why cryo? Because cryo contains fibrinogen, cryo contains factor 8, contain factor 13, clot stabilizing factor, and von Willebrand factor as well. Is that clear? Yes or no? Wonderful. So now
Yes,
this
sir.
is the treatment. Heparin infusion is absolutely contraindicated. Why contraindicated? Patient is already bleeding. If you give the heparin, it will again thin the blood. It will reduces the factor and bleeding is increased. So this is not used. It is contraindicated. Am I right or wrong? Patient is already bleeding, right? So it is used for thrombosis, not for the bleeding. Aspirin used for the thrombosis, coronary artery disease. We use MONA, morphine, oxygen, nitrate, aspirin, stroke, primary, right? Ischemic stroke. We use the aspirin, right? So it is used in the right ischemia, right? Not in the bleeding. So it is contraindicated. It is contraindicated. Platelet transfusion only will not help this patient because there is no problem only in the platelet. Problem is in the PTA, PTT high means in factor in the this. So you need to add the cryoprecipitate as well, right? So this will supplement fresh frozen plasma in fresh frozen means they are frozen very in minus degree plasma. So plasma contains all factor 8, factor 9, factor 10, factor 11, factor 12, factor 7, blah blah. So all factors are most of the factors are contained which take care of PT and APTT, right? Fibrinogen as well, right? And cryo you are giving, so it takes care of this. So treat the underlying cause, give fresh frozen plasma and cryoprecipitate. This is primary. Again, the platelet is not the primary problem. Primary problem is septicemia, and because of septicemia they goes. So give good antibiotic, right? If they are bleeding and platelet is low, you can add the platelet transfusion. You can give the fresh frozen plasma and you can give the cryoprecipitate. Only platelet will not help. That is why it is not most appropriate answer, right? Only platelet will increase from 40 to 80,000. But do you think in absence of the factor, in absence of fibrinogen, blood will clot? Answer is no. You need everything in proper mixture to clot the blood. So if you don't have the proper mixture, you won't get the bleeding stopped. So what is the bottom line of this whole discussion for last 20 minutes? Treat the underlying cause, FFP cryo. Why clinical reasoning? This patient has classical disseminated intravascular coagulation secondary to septicemic shock. Thrombocytopenia, prolonged APTT because of factor deficiency, low fibrinogen, factor deficiency, D dimer, bleeding from venipuncture. So this is classical acute consumptive. Consumption means there are a lot of factor and factors and platelets are consumed. It is why called as a consumptive coagulopathy, and it is none other than DIC. So treat the underlying cause as you rightly told, right? Septicemia, antibiotic, source of control. If pneumonia, you treat pneumonia. If UTI, you treat UTI. If it is a septicemia, GI, the infection, you treat primary. So source control. So wherever the source is coming, you treat it. Antibiotic, fluid and vasopressor, yes, because patient is in shock. So first is fluid, pressor, right? Drug of choice for septicemic shock. No option. Can anyone tell me drug of choice? Once you had given the IV fluid, which is the immediate next drug of the choice for septicemic shock?
Noradrenaline.
Wonderful, brilliant, correct answer. Noradrenaline, noradrenaline, right? So there is one again question. Why not adrenaline? Go and think it. Why not adrenaline? Why not adrenaline? Go and think it. I'll tell you later on. I'll move to the next question. But answer is noradrenaline. Septicemic shock drug of choice is noradrenaline, not the adrenaline. Again question. Why not adrenaline? Find out. We'll see this later on. Right, so this is the thing is, so replace the consumed clotting factor FFP cryo, we already discussed it, right? Heparin, wrong answer. Why? Chronic DIC with thrombosis, right? Not the bleeding, patient is bleeding, so heparin is contraindicated. Aspirin is also contraindicated, absolutely contraindicated, because it worsens the bleeding by inhibiting the platelet. Heparin and aspirin is different. Few people have confusion in the mind. Both are anticoagulant, so not anticoagulant. One is antiplatelet, right? Because, right, so when there is a thrombosis, so there could be a platelet or there could be a factor. Because of this, both the things, right? So when there is a deep vein thrombosis, this is venous thrombosis. Coronary artery, arterial thrombosis. So arterial thrombosis give the antiplatelet agent like ecosprin, aspirin, clopidogrel, right? This is arterial clot. You give aspirin. Venous clot, deep vein thrombosis, you give the heparin. Heparin. Heparin acts on the factor, not on the platelet. Aspirin acts on the platelet, not on the factor. So they have both different mechanism of action. So don't get confused, right? So whenever somebody is saying aspirin, it is antiplatelet, not the anti-factor. When somebody says heparin, it's anti-factor, not the antiplatelet. Both are used in a thrombosis. One is arterial, one is venous. Go and read it, how you differentiate one from another. That's all from my side. So platelet transfusion, wrong answer, because platelet will increase platelet. What you do for low fibrinogen, what you do for low platelet clot, right? So that's it. So this is what the thing is. So I think I'm very much pretty much clear. If audience has any questions, I would be happy to answer. I spend more 15 seconds if anybody has any question. Dr. Savita, is that clear?
Yes, sir.
Wonderful. Now jump to the all three questions. First question, gynecology, right? Second question is surgery, appendectomy. First question is precocious puberty. First question, just let me remind you, I knows everything. Second is appendectomy. Third is septicemic shock with DIC. Now legal and ethics question. Patient refuses a life-saving blood transfusion due to religious beliefs. What principle must follow the doctor? What principle must the doctor follow? It is beneficence, it is non-malfeasance, is it autonomy, or it's a justice? I want the definition of all four. What do you understand by beneficence? What do you understand by non-maleficence? What do you understand by autonomy? What do you understand by justice as well? Because our job is not to just get the answer, rule out all other three, four options as well. So now it's open for all. You place your answer. Those answered 3 out of 3 correct. Score is 3 out of 3. You check your own score. Don't shy to check your score. It is very important for exam. So 3 out of 3, 3 out of 2, 3 out of 1, 3 out of 0 as well. Don't take it otherwise, but check your score. This is fourth one now. Yes, anyone wants to? Yes, Dr. Sonia. So what do you think? What could be the answer?
Sir,
Patient
I think
refuses for life-saving blood transfusion. Patient is required blood transfusion. Let's understand. So patient refuses a life-saving blood transfusion. Probably patient has 4 HB, patient has major bleeding, patient has something wrong, right? And doctor advised that, okay, the gentleman, you need to have a blood transfusion. But what happens? Patient refuses a life-saving blood transfusion due to some religious belief, right? So he thinks that our God is saying no, in our religions, blood transfusion is contraindicated. In that case, What principle must the doctor follow? Tell me now.
So autonomy, because the patient has the right to make the decision about their own medical care, including the right to refuse the treatment. But I'm confused, the beneficence or autonomy? So
Wonderful,
not sure.
wonderful. No, you are right.
Uh,
You are right.
I
It
think
is autonomy.
beneficence.
No, it is not beneficence. Let's dissect it. Beneficence is what? And autonomy. Then we'll get polarity. So now let's dissect the answer. The question is simple, right? Need a life-saving transfusion. Patient is not saying no. What the doctor supposed to do? So this is the understand this. If you listen me properly, all cloud doubts will be gone. Autonomy. What do you mean by autonomy? Ethical reasoning. If a competent adult more than 18 years refuses a life-saving treatment like blood transfusion, some emergency craniotomy, some emergency abdominal surgery, or some emergency life-saving drug or chemotherapy for leukemia, example. So again, if a competent adult refuses a life-saving treatment, this is one of the example, blood transfusion for religious reason, right? The physician must respect the patient's autonomy, patient, right? Because it is right of the patients to say yes or no to the any treatment globally, right? You have to just explain that, okay, fine, blood transfusion is required, otherwise there is a risk of complication, you may die. You explain the patient. It's your job to explain the patient, but eventually or ultimately the patient is the one who will gonna take the decision for himself or herself. Is that clear to everyone? Yes or no?
Yes, sir.
So now
Yes.
let's see what is autonomy. So patient's right to make their own decision. Patient has a right legally to make their own decision, even if the decision may result in a serious harm or death. Even you feel that if this treatment is, if I feel that this in leukemia, if the chemotherapy is not given, he will going to die soon, right? I explain the patient, but still patient is saying, I don't want to take any kind of chemotherapy. Even if I die, that's fine. It's your job to make them understand. So this is what is the beauty and interesting sentence here to have a simple definition. Patient's right to make their own decision even if the decision may result in a serious harm and extremely the death. It's patient's right. So here patient's right is autonomy. Patient who understand the risk, death if not transfused, the benefit of life saving, and still if he refuses to choose, it is legal and ethical right to do so. Let the patient, and that is why the consent is required for each and every patient, whether you perform a tympanoplasty, appendectomy, tonsillectomy, or hysterectomy, or any kind of surgery. Without consent of the patient, it is not. It is not. Good idea to go ahead without the consent of the patient. This is the reason, right? So even not the plan one, even in the life threatening, what they are mentioning, right? If the competent adult refuses the life saving treatment, not just the transfusion, any life saving, because of not just religious, any reason, physician must respect the patient's autonomy or his own decision. Let's dissect beneficence. What is beneficence? Beneficence is equal to doing good or acting in the patient's best interest. It is called beneficence. So, okay, you have malaria. I'm giving the anti-malaria treatment. It is good for you. This is beneficence. In the good for the patients, doing good or acting, doing or acting by and large the same in the patient's best interest. So every doctor is doing beneficence to the patient. Every doctor is advising good for the patient for the betterment of the patient. It is beneficence, right? But autonomy means patient has to take a call, patient has to decide whether to do it or not. That is called autonomy. What is non-malfeasance? Non-malfeasance is do no harm. Do no harm. Forcing a transfusion against patient will is harmful ethically, even if the medical intent is good. So you cannot force the patient to take any kind of treatment. You are going to give the transfusion, but because think what happens if the patient die because of transfusion reactions, because of TRALI, transfusion related acute lung injury, because of die because of any bad severe anaphylaxis, especially in IgA deficiency, blood transfuse, then it's not a good idea. So take always the consent. Non malfeasance is forcing a transfusion against patient's will is harmful ethically, and even if the medical intent, even though your intent is good, you want to save the patient, right? But you cannot force. Do not harm. And justice wrong. Why? Justice refer to a fairness, equal distributions of the resources, not individual treatment decision. That is justice. So justice refer to fairness or equal distributions of the things. So concluding our talk here, though the simple questions, we need to understand what is the concept. So patient refuses life-saving blood transfusion due to religious belief. What principle must the doctors follow? It is a autonomy. Let the patients to decide. So autonomy is the right of the patients. Ask each and every patient, even it is not in favor. Patient many a times take wrong decision, right? By their own, by the Google knowledge, they take wrong decision, but it's their choice. You cannot force it. Is that clear, everyone? Yes or no?
Yes,
Yes, sir.
Yes, sir. But
Wonderful.
the steps which the doctor should follow would be discuss about the blood transfusion benefits, no, sir.
Yeah, obviously, no, whenever we are giving any treatment, doctor, to the any patient, right, we supposed to tell both the things, plus and minus. Say, for example, I'm giving you my example in my day-to-day job, right? Chemotherapy. So chemotherapy is good. I had a young female, 25 years female, breast cancer. I'll give the advantage. Okay, chemotherapy increase the, it reduces the morbidity, mortality. Probably if you cures, you will live long years, right? Disease-free interval is good, quality of life is good, and you are free for cancer. These are the advantage. What are the disadvantage? Hair loss is there, nausea, vomiting is there, GI upset is there, because of chemomyelosuppression is there. I need to tell pros and cons of the treatment to the patient, each and every patient. Let them decide what they want to do. Is that clear? Yes or no? Likewise, for blood transfusion,
Excuse me, sir.
for any
Sir,
treatment,
Yes,
I
sir.
want to
whatever is.
ask,
Yes.
sir, if the patient is under 18, the then rule will be changed?
Under 18 rule will be changed, or unconscious patient rule will be changed. Patient is adult, 25 years, but unconscious. Who will gonna take the decision? You understand? In that case, probably not much in India, honestly speaking, but in foreign world, they involve the ethical committee. You know, ethical committee,
Yeah.
right? So they may wants to make sure legally that they are doing well, and there is nothing, no issue in the future. Oh, who had given the consent? Why you operated my brother? Blah blah. He died later on, right? If you did don't operate, he will live long time, right? Why did you want wait and watch? Blah blah. Probably you are facing the same thing in your practice every day. This is a everyday problem, right? So we need to be very vigilant, right? So when there is a patient is unconscious or below 18, right, then rule will be changed, right? So let's move. You read all four the things once again. We'll discuss again. So
sir.
go and read it all four terms in these things. Now there is no option for these questions, right? It is spot diagnosis. It is as in exam. It is asked in the same way. Spot diagnosis means no option. Spot diagnosis. Identify below skin condition. You look at the skin condition, identify the below skin condition, no option, spot diagnosis, what is the treatment, right? So here there is no investigation here, right? So you need to know the three things. Diagnosis, so first you need to know the diagnosis, right? Investigation, what you supposed to do for this patient, and what you gonna treat, how you gonna treat. So you see, look at, probably if you can see here, this is the culprit, rest of the thing is fine. What do you think? Eczema or what, or drug induced, or whatever? What do you think? And describe it. Somebody who is like practicing in dermatology, probably in the group, right? You can describe it that, okay, fine, this is the condition. Yes, anyone? Any guess, any
Sir,
Sir,
comment?
he's
just
having
scaly
dry skin,
patches.
Any white patches?
Yeah.
Yes, Saranya.
ichthyosis.
You
And
you
the
tell me the
hospital.
diagnosis one by one. Tell me the diagnosis. I'll make a list of the diagnosis.
Sir,
Psoriasis, sir.
Sir, Psoriasis.
eczema, it can start with eczema.
One is eczema.
uh,
Okay,
my answer would be ichthyosis vulgaris.
vulgaris. Second diagnosis. Third,
Psoriasis.
Psoriasis.
Yes.
one is
Psoriasis.
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 Psoriasis. Fourth, any fungal infection, or anybody think of something?
Candid infection in this area is pretty rare.
Bad, yeah.
Wonderful. So fungal infection is where? Wonderful. Brilliant. I'm just trying to understand. I'm trying to make your neurons active. Fair enough. Anything else you think? I mean, see, differential diagnosis should be long. Then you can triage one by one. Oh, why not vulgaris? Why not psoriasis? Why not eczema? Why not this, that, blah, blah. Right?
It's not because of drug inducer because the question doesn't have any drug.
So any allergy,
So
contact
any
dermatitis?
questions you want me to ask, or you want, right, to ask me? Ask. I tell yes or no. If you have some question in mind, you can ask me.
Is the
Exposure to
patient is
any
exposure to
detergents
drugs?
or exposure to any
Drugs.
chemicals?
No chemical now. No chemical.
So
Answer.
this is psoriasis
Next.
due to the location.
Yeah, because
Wonderful.
of the extensor areas,
Very
elbows.
common, very
Wonderful,
common on the
brilliant,
elbow.
wonderful,
Very common
wonderful. So
on
those who
elbow.
had given answer psoriasis, it is correct. Write down your score out of five. This is maybe fourth, fifth question, right? 5 out of 5 or 5 out of 2 or 3. You check your score. Later on, send it to me, right? If you shy, don't send it in the group. Send it to me directly. This is my permanent mobile and WhatsApp number. So don't hesitate to contact me. I'll get back to you as soon as possible. Wonderful. So let's dissect. Let's dissect why this not. Again, our main job is to why this not. So spot diagnosis, plaque psoriasis or psoriasis vulgaris. Why this diagnosis image includes well-defined erythematous plaque. Let's see, is it well-defined? Yes. Erythematous plaque? Yes. Let's go second. Covered with the thick silvery white scale. Very beautiful word, silvery. So looks like a silvery. So silver is a psoriasis, silvery psoriasis. Silvery white scale located on the extensor surface. Yes, extensor. This is elbow, right? So this is extensor. Front is a flexor, back is a extensor. So this is extensor, right? So located on the extensor surface, especially the elbow. Classical site. Most common site for psoriasis is extensor surface of elbow, and it is there only exactly. So everything is fit and matching. Chronic, sharply demarcated appearance. This appearance is diagnostic of psoriasis. What is psoriasis now? So psoriasis key features: chronic autoimmune skin disease, extensor involved elbow, and then extensor of the knee and the scalp, lumbosacral. These are the common. Most common is elbow. What we see is the elbow, right? Third, Ortspitz sign. What do you mean by Ortspitz sign? So Ortspitz sign is a pinpoint bleeding when scale removed. So when you remove the scale, there is a bleeding. There is a bleeding. This is Ortspitz sign. Once again, what is Ortspitz signs? Ortspitz signs is a pinpoint bleeding when you remove the scale. Kobner phenomenon. What is that? New lesion at trauma site, right? And nail changes, pitting and onycholysis. These are the classical features of psoriasis. So this is not none other than psoriasis. How you differentiate with the contact dermatitis?
History, history of exposure.
Okay, wonderful.
Appearance.
How is the
Itchiness.
appearance? Can you describe little bit, like this is a extensor surface, white silvery scale, on bleeding there is a Auschwitz sign, on trauma it is a again this thing. So how you describe the eczema in a one word? If you want to describe, say for eczema, I can
Erythematous.
tell you. Okay, what else? Only erythematous could be many things.
Blisters, sir. Blisters, rashes.
No.
Fine. So I describe it. You listen it. Probably it helps you. So eczema is a chronic, relapsing, inflammatory disorder of the skin characterized by itching, erythema, vesiculation, oozing, crusting, and later scaling and lichenifications resulting from epidermal barrier dysfunctions and immune hypersensitivity. Looks complicated but simple. So eczema is a chronic skin condition. It's an inflammatory disorder of the skin. The commonest presentation is itching, erythema, oozing, and vesiculations, right? So it's a immune hypersensitivity, probably T cell mediated, right? So that is the things, right? So you need to know. Now let's jump to the next questions as well. How you supposed to treat this patient? Local application, systemic application, immunosuppressant, IV antibiotic, IV steroid, topical steroid, oral steroid. How you supposed to treat the same picture? If this patient comes to you tomorrow morning, your OPD, how you gonna manage this patient?
So
So
topical
he
Topical
has no
steroids
steroids.
lesion.
oral also.
He has no lesions anywhere else, sir. This is the only single lesion he has.
Usually, this is only single lesion.
Topical
Then
steroids, sir.
topical would be more preferred
Topical
than.
emollient to moisturize the skin, and in psoriasis, the trigger factor is also there to avoid the trigger factors also.
Fair enough. Wonderful. So this is what the thing is, stepwise approach, treatment of plague. This is plague psoriasis, right? So what do you do? Topical corticosteroid, first line. We are talking about the first line, right? First line and second line. If first line doesn't work, then second line. So first line treatment is a topical steroid, right? These are the drug betamethasone and cobitazole. Vitamin D analog can be used. Combination therapy can be used, and moisturizer and keratolytic salicylic acid. Second line, right, can also be used, like tacrolimus. It's an immunosuppressive agent, right? So this is the general treatment, right? But you start with the simpler one, topical corticosteroid. Moderate to severe psoriasis, large area or resistant. In that case, what you do? Phototherapy. You give the phototherapy to this site, right? That is the treatment. And another is a systemic agent or immunosuppressive agent like methotrexate, cyclosporine. So that's all. That is what the treatment is. And in severe refractory cases, you can see lots of monoclonal antibody, adalimumab or infliximab, right? And a lot of interleukins inhibitors are also there, and many are there in the pipeline as well, right? So short exam answer: diagnosis is plaque psoriasis, treatment is topical, means local application, high potency steroid and vitamin D analog you can use, and in extension immunosuppressive agent. So that's all. This is the next questions in front of you. What is the Keher sign? What is a Keher sign? In this, we are discussing 30 signs, 30 clinical signs. What is a Rosing sign? What is obturator sign? What is a Murphy sign? Right? What is a Turner signs? What is Cullen sign? Like 30 signs we are discussing in this question. So your this question contains 30 MCQ. Believe me. And they can ask you anything, believe me. First of all, I want to know what is Keher sign. Right? Is it pain radiating to the groin? That is Keher sign. Left surgical question. Left shoulder pain due to splenic rupture. Third question. Pain on the deep inspiration with right upper quadrant tenderness and deep pain on the internal rotation of the hip. That is Keher sign. So Keher sign is what? It is seen in which condition? How you elicit the Keher signs positive? Yes, anyone? Any volunteers want to comment on this? I would be happy.
It's because of splenic injury, sir. Like left shoulder pain, it'll be there.
Splenic rupture.
Yeah, spleen injury.
Spleen injury. So your
Yes.
answer, as per what I understood from your talk, is your answer is B, if I'm not wrong, right?
Yes, sir.
Okay. So what happens in a Keher sign?
Um,
How you get pain on the shoulder when there is a spleen is rupture? Spleen is in the left upper quadrant of the abdomen, and you have pain on the left side. How it's
because
possible?
because of the phrenic
Diaphragmatic
nerve,
irritation.
diaphragmatic irritation, and the phrenic nerve through the phrenic nerve.
Fair
It's
enough.
referred
That
pain, sir. It's a referred pain to the
wonderful,
left shoulder.
wonderful, wonderful. So those who did not get the good answer or right answer, let's correct it. The answer is B, left shoulder pain due to splenic rupture. It is called positive Kehr sign. Kehr sign is equal to referred left shoulder pain caused by diaphragmatic irritation, most commonly due to splenic rupture. Right, so when there is a diaphragm is disturbed, diaphragm irritation, it could be in the splenic rupture because just above the spleen there is a diaphragm. Another is a hemoperitoneum, lots of blood in the peritoneum, it irritates the diaphragm. And diaphragmatic irritation from the blood or any fluid collections, right? You should left shoulder pain. So whenever something wrong, so diaphragm is irritated by anything, either retroperitoneal hemorrhage or splenic rupture or fluid or anything, massive ascites, you have left shoulder pain, you can say positive Kehr sign. Is that clear to everyone? Yes or no?
Yes.
When blood collects under the diaphragm, the phrenic nerve C3, C5 is stimulated, producing pain felt at left shoulder. Right?
Sir, patients come with dyspepsia also with the same shoulder pain. Can that be the same sign, sir, or it's only when the fluid is
Dyspepsia,
collected we
not.
say
No,
that?
no, 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 not dyspepsia. When you have peritoneal or diaphragmatic irritation and then there is a things, dyspepsia is not Kehr sign. Right, so now these are the answers, right? So what are the options here? Pain in a groin, left shoulder, pain in the inspiration. So let's dissect. So this is what we cleared, understood. Now when there is something wrong in the irritation of diaphragm, these signs can be elicited or labeled as a positive when you have a left shoulder pain. Why not the pain radiating to the groin? What is pain radiating the groin? It is a ureteric colic, it is a testicular torsion, not the positive Kehr sign. So that is not the answer. Why not the pain on deep inspiration with the right upper quadrant tenderness? It is called as the Murphy's sign, seen in the acute cholecystitis, right? Not the Kehr sign. And last but the not least, pain on the internal rotation of the hip. It's a wrong answer. Why? It's a obturator sign. So when you have pain on the internal rotation of hip, you have a pain. It is called as the obturator sign. It is seen in the pelvic appendicitis. So appendix has a many condition, right? So if the pelvic appendix is situated right in the pelvis area, right, at that time when you internally rotate the hip, there is a pain. It is called as the obturator sign. It is seen in the pelvic appendicitis, means appendix is situated in the pelvic region, right? So final answer is this, Kehr sign, left shoulder pain. Now comes 30 question, 30 questions, what we are talking about. So I'll go little quickly, you can later on understand. Kehr sign referred as a left shoulder pain due to diaphragmatic irritation seen in splenic rupture or hemoperitoneum. Murphy's sign, arrest of the inspiration while palpating right upper quadrant at the lever side when you are palpating and patient has a arrest of inspiration. When they are doing inspiration and you palpate, they arrest. Why? Because there is an inflammation on the gallbladder on the right upper quadrant seen in the acute cholecystitis. A rousing signs, pain in the right iliac fossa when left lower quadrant is palpated. So when the left lower quadrant palpate, there is a shift of the pressure on the right. It is seen in the appendicitis. So rousing signs, important sign, right? So appendix is in the right iliac fossa. You are pressing the left iliac fossa. So when you press the left iliac fossa, pain in the right iliac fossa, it is called as a rousing sign seen in acute appendicitis. Psoas sign, pain on the hip extension, right? Retrocecal, pelvic appendix, retrocecal appendix, right? So when appendix is behind the cecum, right? When you do the hip extension, there is a pain. Psoas sign positive. Obturator, just now we seen pain on the internal rotation. Pelvic appendix, this is retrocecal appendix. Gray Turner and Cullen. Cullen is umbilicus. This is abdominal cavity, right? Coolan means umbilical. C means umbilicus. C means coolan. C means umbilical. C means coolan. C means umbilicus. Cus means coolan. Right? So peri-umbilical, seen in the pancreatitis. Right? Gray Turner, seen in a pancreatitis. Both are in pancreatitis, but this is peri-umbilical coolan and flank on the side, flank. Retroperitoneal hemorrhage. It is called as a Gray Turner. Gray Turner. Coolan. C for umbilicus. That's it. So, Great Turner sign is flank ecchymosis that is seen in the acute pancreatitis, collapse, and peri-umbilicus bluish discoloration because of ruptured ectopic or pancreatitis. Both you can see. Battle sign. What do you mean by battle sign? So, they are asking many times. Battle sign. Mastoid. On the mastoid bone, there is the ecchymosis. It is usually seen in the basal skull fracture. Recons eye, periorbital. So, this is eye, right? This is eye. This is isoperi-orbital ecchymosis, red or black areas behind the ear. This is also seen in the basilar skull fracture, or sometime I think so. I don't know. Panda sign. Panda sign is they are also called panda sign. So raccoon eye or panda sign. Raccoon eye, right? So it looks like a animal raccoon, right? So raccoon eye, right? These are the Cho stick sign. What do you mean by Cho stick sign? And Trossos sign, right? Trossos and Cho stick sign both are seen in hypocalcemia. Joystick is when you twitch the facial muscle, there is a facial nerve irritation, right? And facial muscle twitching, it is seen in the hypocalcemia. So that is seen, right? So we see, especially in hypocalcemia, joystick sign we evaluate, right? Just the little this tap on the facial muscle, there is a twitching of the muscle seen in the hypocalcemia. Carpopedal spasm after BP cup inflation. So if you cup BP cup inflate, there is a carpopedal spasm, hypocalcemia. Homan sign, pain on the dorsiflexion of the foot. There is a pain. It is called deep vein thrombosis. Chronic sign, pain on the knee extension with hip flex meningitis. Brudski's sign, same the hip, knee flexion, neck flexions, meningitis. Courvoisier sign, painless jaundice, palpable gallbladder, pancreatic cancer. Simple thing. Pancreatic cancer, palpable gallbladder. Pancreas cancer, palpable gallbladder, right? Because of the duct is like collapse or duct is narrow, there is a palpable gallbladder and jaundice. Murphy's triad, pain, fever, vomiting. Appendicitis, Murphy's triad. We have seen just now. Charcot's triad, right upper quadrant pain, jaundice, fever. How you differentiate from Murphy's and Charcot? Here the jaundice is there, appendix jaundice is not there. As simple as that. So Charcot's trial, pain is there, fever is there, but jaundice, it is Charcot, vomiting, appendix. Reynolds phenomenon, right? Septic cholangitis. Cholangitis means inflammation of common bile duct. That is called cholangitis. Inflammation of bile duct. Virchow's node, left supraclavicular lymph node, it is seen in the gastric carcinoma. So every time whenever my patient comes with a CS stomach, I always look into the left supraclavicular lymph node. If it is there, my diagnosis is more strong. Gastric carcinoma, it is a Virchow's node. Sister Mary Joseph nodule, umbilical metastasis, GI malignancy. So if you have a GI malignancy like a small intestine, large intestine, colon, colorectal, blah blah, GI malignancy in general, gastrointestinal malignancy, look for the umbilical metastasis. If it is present, it is called as a Sister's Mary Joseph nodule. Then Bloomberg sign, rebound tenderness, peritonitis, right? Dance sign, empty right lower quadrant in children, intussusception. So when you have intussusception, the intestine go one in another, it is called like, right? That is why right lower quadrant is empty, it is Dan sign. Right? Fodgill signs, it is abdominal mass remain when the rectus contracts, rectus sheath hematoma. Then Pembrunton signs, facial congestion when arms raised, it is a substernal goiter, right? The Lermit signs, it is electrical shock down spine on the neck flexion. It is multiple sclerosis, B12 deficiency. TAPS dorsalis sign, positive Romberg neurosyphilis. This is Melina sign, black terry school, GI bleed. Blueberry muffin baby, pruritus nodule in newborn, torch infections. Chandelier signs, very common, cervical motion tenderness in pelvic inflammatory disease. And Lesh Nyhan signs, it is self mutilation behavior, HGPRT enzymes deficiency. So don't get confused or don't get disappointed by all these signs, but I want you to open up your mind and brain. These are the common signs they ask in the exam. So I thought let me not just include the Keher sign, but these are the sign also available, which is like very frequently commonly asked, and you must have to know. So you can take a picture later on, or you can take a screenshot from the website. No problem, no nothing to worry. So that's all. So let's jump to the next questions. This is also long questions. We probably cover a couple of more questions, then we'll stop. So just keep bit more patience. I'm still energetic. So 5 years old boy is brought to the emergency department with severe respiratory distress. Mother reports that my baby has fever for 3 days, fast breathing for or fast breathing since morning, and poor feeding and lethargic. This is what the condition of baby, 5 years old baby, brought to the emergency with the chief complaint of severe respiratory distress. Along with that, mother is adding that baby has fever for 3 days. He has a fast breathing since morning, that is respiratory distress, and she has a lethargic and poor feeding. On examination, temperature is 39, heart rate is 150, respiratory rate is 58. Blood pressure is 90/60, SpO2 is 84, chest indrawing positive, nasal flaring and grunting, auscultation reduced, air entry on right side and crepitation, capillary refill is 4 seconds, child is irritable but arousable. This is what the complete exhaustive vitals examination of this baby. Now the job is to do what is the diagnosis, right? Still question is not finished. So this is a condition, this is a examination. Now what about the laboratory test? So lab shows CBC 18,500 with 86% of neutrophilia, hemoglobin 10.2 of this baby, 5 years, platelet is 380,000, CRP, C-reactive protein is increased, chest x-ray is right lobar consolidation with the air bronchogram, ABG pH is 7.28, PCO2 is 52, PO2 is 52 on oxygen. What is the most likely diagnosis? Acute severe asthma, pneumonia with severe respiratory distress, foreign body aspiration, acute bronchiolitis. Take your own time. I think it's a little exhaustive, but important. This is the question. This is the lab. This is the question. This is the lab. Think over it 10-15 seconds. Nothing to hurry.
It's a pneumonia with severe respiratory distress, sir.
Okay, pneumonia with severe respiratory distress. So how you differentiate from acute severe asthma? Let's discuss now. Our job is
Yeah.
to help others as well. Yes.
Fever is not seen in as not common in
Asthma.
asthma.
Sorry.
Fever is not in asthma, sir.
Fever and the labs
Auscultation.
show that it's an infection rather than
Infection.
asthma.
Wonderful, brilliant. So this patient is presenting with the it's a acute. So yeah, you tell sir whatever the points you remember, tell open for all. So fever, acute thing since the morning, right? And severe respiratory distress, right? And they not mention about silent chest or something like this things, right? So temperature, tachycardia,
Temperature
increased
disorder.
respiratory rate,
Okay. Hypertension.
things, hypoxia, chest indrawing,
Drawing,
nasal
grunting.
flaring. Auscultation is also reduced air entry,
Crepitations.
crepitation. So crepitation is also not in there in the asthma, isn't it? Yes or no?
Yes, sir.
So considering all the things, yes, answer is correct. Pneumonia. So pneumonia with respiratory distress. Let's dissect little bit. Why pneumonia? Feature what point favoring pneumonia? Always ask these questions to each and every MCQ while you're preparing. Fever with toxic appearance, lobar consolidation in X-ray, neutrophilic leukocytosis, hypoxia with respiratory distress, reduced air entry, and focal crepitation. The child has a feature of shock prolonged CRT. This makes severe pneumonia, right? So this is a bad pneumonia, right? So need ICU and treatment. Why not the other option? That is more important. Why not acute asthma? That is what our matter of discussion, right? So let's see why not asthma. So asthma shows diffuse wheezing, not the crepitation. There is a hyperinflation on the chest X-ray, not the lobar consolidation, and not the focal crepitation. This is one thing. X-ray usually in asthma shows hyperlucent lung, not the lobar consolidation. And usually they don't have any fever or they don't have any leukocytosis typically, isn't it? Are you agreed with me? Yes or no? Right?
Yes,
So
sir.
this is not favoring. Foreign
Acidosis,
body always,
acidosis is also there, sir, in this
yes,
patient.
wonderful. Yes, true. 7.35 less than is acidosis, right? That is because of respiratory
Sepsis.
distress and all. So
And
sudden onset.
X-ray also shows consolidation.
Consultation.
Wonderful. Yeah, that is what they are mentioning. The X-ray in asthma shows hyperlucent lung, while in consolidation, right, you can in the things that you can see the all congestion or consolidation in the lung. Foreign body aspiration, sudden onset, choking, coughing, unilateral hyperinflation, right, and not associated with a fever and high WBC count. X-ray shows consolidation, not hyperinflating or air trapping. So this is not, there is no history of foreign body or aspiration and not classical. Acute bronchiolitis, it is usually seen in infant less than 2 years. Our baby is 5 years. Patient usually present with the wheeze, not the crepitation, right? And viral usually normal or mildly increased elevated RBC count, WBC count, which is not the case here. So what is the take home message for this or high yield point for this MCQ? Let's discuss. So lobar consolidation, high fever, neutrophilia, bacterial pneumonia, which fits to our case, isn't it? We have lobar pneumonia and consult chest X-ray. Patient has a high fever, patient has a neutrophilic leukocytosis, probably bacterial pneumonia. SpO2 less than 90, chest indrawing, severe pneumonia, WHO classes. That is also fitting, right? And considered fluid bolus treatment, right? Sepsis, that's fine. So anyway, this is pneumonia, not the foreign body, not the bronchiolitis, not the other things as well, right? So that's it. Just spare. Is it okay if I can take one more questions, or you are
Yes,
tired?
sir.
Yes, sir.
Wonderful. I'll take one more last for this. So then we'll have some feedback. 52 years in this question, almost 20 questions involved. 20 questions, like 30 sign here, 20 questions. The question is one, but we'll solve 20 MCQ. 52-year-old asymptomatic woman visit a primary care clinic for a routine health checkup. Listen each and everything, important. 52-year-old asymptomatic woman visit a primary care clinic for a routine health checkup. She has no family history of cancer, attended attained menarche at 13 years of age, menopause not yet attended, and has two children. She does not smoke or consume alcohol. His body mass index is 29 kg per meter square, right? What are the questions? What cancer should be screened for according to standard population based screening guideline? Right? You need to answer this, right? There is no option. So, first question for this lady: what cancers should be screened for according to the standard guideline? What screening tests should be used for each cancer? I want to know, right? What screening test you can use for each cancer, like lung, breast, colon, prostate? At what age should screening be started, and how frequently should be done? This is long question. Mention one cancer for which the screening test is not recommended in asymptomatic, right? Average risk individual and why. So first answer this question. One cancer for which the screening is not recommended. Like breast mammogram is recommended. For cervix, PAP is recommended. High
Ovarian,
risk, sorry,
ovarian carcinoma.
ovarian carcinoma. So we got the answer one, ovarian
No.
carcinoma. So now I want to know why not? Why not? Why not? Why there is no screening test for ovarian carcinoma? Isn't it a 1 CA 125? What do you think? Yes or no? You give your own
Yes,
answer.
Asymptomatic,
sir.
I can
asymptomatic
confuse you.
individual. We are seeing for asymptomatic individuals, sir. So,
No, but I want to know what they are asking. Listen the questions once again. Mention one cancer in the body for which screening is not recommended in asymptomatic average risk or asymptomatic patient. Forget about all this tricky word. So simple question. Give me the name of the one cancer where the screening is not recommended in asymptomatic patient. That's it,
Breast
right?
cancer?
Breast cancer. So
No.
breast cancer, it is not recommended.
No,
We are
no, no, no.
recommending
Recommended.
very
We are not
widely.
recommend widely mammogram.
No,
In,
ovarian cancer.
Why not endometrium,
Widely
sir?
recommended.
in breast cancer, we
Endometrium.
are widely. This is number one where we promote the screening, even if though it is asymptomatic after 50.
Mm-mm.
So breast is not the answer. Rather, it is highly wrong answer. Yes,
Endometrium, sir.
endometrium. Okay, fine. What else? One
Mm.
answer is endometrium.
Lung cancer.
Sorry?
Lung cancer.
No, that is also wrong answer. Lung cancer we recommend. Na? Those who are a heavy smoker, 20 pack per year, we do the test called as a low dose CT scan. Low dose CT scan. It is highly recommended for chronic smoker to detect the lung cancer in early stage. Highly recommended. Here, what they are saying, right? Not recommended. Fair enough.
Pancreas, sir.
There are a lot of cancer, pancreas, even gallbladder you can answer, but the common one. Anyway, so let's see. I mean, I'll dissect this question. Fine. Now this is done. I mean, in general, this is we got little idea, right? We will discuss. This is last question, so bear with me 5 more minutes. Can anyone tell me for this lady, 52 years of lady, who is asymptomatic, what cancer should be screened for this lady? For this lady, 52 years.
Breast cancer, cervical
Breast and
cancer,
cervical cancer.
colon.
Cervical
Breast
and
cancer.
colon cancer.
Breast,
Breast,
cervix.
cervical, and
Breast,
colon.
cervical, and colon.
Any other?
Colon cancer.
Colon cancer.
No, as she is
Cervix,
obese,
breast, cervix, and colon. Any other
Colon.
things you want to
Mm.
add?
as she has
Wonderful.
high
Stomach,
BMI,
stomach, sir, stomach.
then as she has high BMI, so we should go for the ultrasound liver also to rule out the
Yeah.
further.
Fair enough. So we'll
Sir,
see the answer. What is
I would suggest endometrial carcinoma also, since she has
Endometrial.
not attained menopause.
okay? Fair enough. Wonderful. Now, what screening test should be done for each cancer? We'll see it. At what
See,
age we should screen to start and what frequency and what test? And there are a lot of questions, hundreds of questions. So now let's go with the literature. I'm always come with the literature. This is the things. So we are talking about our lady, 52 years old asymptomatic woman. So first question, what cancer should be screened for? So now this is one question. Cancer to be screened for at 52 years. So breast cancer, you are absolutely, everybody has given the brilliant answer. So breast cancer usually, right? We recommend 50, absolutely. In high risk, we can even recommend after even 40 as well, right? First degree relative, if you have, you can start in high risk after 40. Our lady, remember 52. So after 50, each and everybody, our mother is deserve. Our mother, if it is more than 50, she deserve mammogram. Even though it is asymptomatic, no lump in the breast self-examination is normal, clinical breast examination is normal. Our mother deserve bilateral mammogram after 50 years of age, preferably every year, if not every 2 yearly. Is that clear to everyone? Yes or no? Any doubt? Ask me.
Yes, sir.
Wonderful.
Yes.
Cervical cancer, I will discuss, right? So 21 year we supposed to start 21 continue till 65 21 to 65 you is supposed to continue, right? Name of the test is a pap test, pap test, right? Name of the test is pap test. We need to do the pap test, right? So pap test we can do for cervical cancer, pap test, right? Or you can do the HPV, human papilloma virus, DNA, right? And colorectal stool for occult blood and endoscopy. We'll see it. So, but for first question number one, what test in our lady who is 52 years of old, what screening test are recommended? So you tell this lady, you go and do the mammogram, you go and do the pap smear, you go and do the stool for occult blood, or every 10 year one time endoscopy or colonoscopy. Is that clear to everyone? Yes or no?
yes, sir.
Yes.
Yes, sir.
Breast cancer, I told you mammogram, cervical cancer, pap
That's
smear, or HPV, human papilloma, colorectal, fecal for occult blood, or stool for occult blood, blah blah, on colonoscopy. These are the tests. So who deserves and what test we seen? Now we go to the next questions, second number questions. Age of initiation and frequency. So breast cancer start age is 40 to 50, especially in 40 breast is young, dense, so it is more sensitive and specific after 50, but most guidelines says 50, but in high risk you can start at 40. The name of the test, three things: what age you start, this age, what test you do, mammogram for breast, frequency every 2 years, if feasible you can do it annually as well, right? Rational is what, why you want to do it, detects early non-palpable lesion, reduce mortality. How come reduce mortality? By detecting the cancer in early stage. Earlier the stage, better
Early
the
time.
prognosis, right? So stage 1 breast cancer, overall survival 90%. Stage 2 cancer, breast cancer, overall survival 70%. Stage 3 breast cancer, 5 years overall survival is 50%. Stage 4 cancer, 5 year overall survival is 10%. So changing the stage will change the overall survival of the patient. Another question in exam, what is the biggest prognostic factor for the breast cancer? The answer is stage of the cancer is biggest prognostic factor. Earlier the stage, longer they live, higher the age, shorter they live. I'm trying to make it on most simplest way, being a medical oncologist. Is that clear? Yes or no?
Yes, sir.
Cervical cancer. Again, three questions: start, age, and taste. So start 21 years, stop at 65 years, right? 20 to 29 pap smear every 3 years, and 30 to 65 pap every 3 years. There are three guidelines. 21 to 29, you do pap smear. After 29 or 30, you have two options. Either you go for pap smear every 3 years, that is same, or HPV DNA test every 5 years. So if somebody say, oh, I don't want to do the pap smear, right? That's fine, no problem. Go for HPV. Eventually, we look for the some changes because of HPV only. And in a non-HPV female, very rarely they develop cervical cancer. 90% plus cervical cancer patients are HPV positive. That is human papilloma virus, and there is vaccine against it. That we'll see in our medical oncology lecture or mock test, and co-testing 5 years. So HPV you can also do. What is the rational? Detect CIN. What do you mean by CIN? Cervical
Intraepithelial
intraepithelial
ectasia.
neoplasia. That is grade 1, grade 2, 3. That also we see and look into the oncology lecture. So CIN before invasive cancer develops. So first is normal. If you don't do CIN1, CIN2, CIN3, then carcinoma in situ, and then it is invasive cervical carcinoma. So we are trying to prevent it from going to CIN, which is the very earliest stage, which is not the cancer, right? To prevent it into the invasive cancer. So by detecting the cancer in early stage, you probably save the life by detecting in very early stage. So here you detect, you cannot prevent, you can detect. Here you can detect. Screening, the purpose of screening is to detect any disease in early age. We are doing the body checkup for our parents. Why we are doing cholesterol, lipid profile, vitamin D, B12? To detect in early stage. They don't have any symptoms. You are forcing them to do every 6 monthly annual body checkup. That is screening. Patient has no symptoms. You are trying to detect in early stage, like diabetes. Is that clear to you? Yes or no? So
Yes,
cervical
sir.
pap smear is there, breast. This age you must remember. Huh? They can ask you any question among this chart or block. Right? Colorectal cancer, again age 50 years usually, fecal for occult blood once a year or annually, colonoscopy every 10 years. Same thing. Principle is same, to detect cancer in early stage. That's it. Any screening purpose is same, detect cancer in early stage. Cannot recommend it for routine screening. Cannot recommend it. You must know it. Right? Why not screened? Ovarian cancer. The answer is ovarian cancer usually. Why not screen? Not effective screening test. CA125. Just let me tell you, right? Many people are saying CA125 is a tumor marker for cancer. So CA125, let me tell you, it is positive in all GI infections, metastatic breast cancer, ovarian cancer, peritoneal cancer, GI cancers, and lot of things. So CA125 is a non-specific, specificity is low, right? That is why the specificity is low. It is mentioned, specificity is low, right? So it is not effective. It is present in benign condition, it is present in malignant condition, it is present in tuberculosis, it is present in metastatic. Yesterday I have seen my patients, metastatic breast cancer. Normal CA125 is 0 to 35, he has a 1000, but not a ovarian cancer, just for your kind knowledge, right? So it is non-specific, or specificity is very less. It is why not required. High false positive rate, right? And no mortality benefit. This is the biggest advantage. No mortality. Whether you do it CA125 or not, patient will live the same. No mortality benefit shown in average risk woman. High risk woman, it's a different story, but average risk general population, no advantage. So here the screening test is not recommended, is for ovary, because no good screening test. If you do the mammogram annually, you reduce the death. If you do the pap smear 3 yearly, you reduce the death. If you do the this colonoscopy every 10 years, reduce the death. You do CA125 annually, it does not reduce the death,
In the day.
no mortality advantage, right? That is why it is not done. And this is the last chart for today. So this is very brilliant chart. I got it for you. It is not in the book or MTB. So cancer breast screening test mammogram start at 40 to 50 every 1 to 2 years. Cervical PEP or HPV 21 to 65 every 3 to 5 years. If you add with the HPV, otherwise only alone PEP 3 years. Colorectal annually, fecal for occult blood 10 years, this colonoscopy. lung cancer, high risk, 20 cigarette pack per year, low dose CT scan, 50 years to 75 years. Try to do it yearly. And prostate PSA not routinely done, same like ovarian cancer. If patients wish, as per the book, if patient wish, you do it with the urinary symptoms. If patient doesn't wish, don't force it. But mammogram, force it. Tell your mother, go and do it anyhow. Do it. Mortality advantage reduces the death. That's all. And last slide for today's sessions. Common exam traps where you do the mistake. CA125 is not a screening test for ovarian cancer. PSA is not recommended for routine population until and unless patient insists. Low dose CT scan is strongly recommended, especially in high risk patient like heavy smoker. The definition of heavy smoker is 20 pack per year. And last but not the least, HPV, human papilloma virus, DNA testing preferred after 30, not from 21 to 30. So that's all from my side. Thank you very much for listening me coolly and calmly. So before I end up my session, I would like to have little quick feedback. How did you enjoy the class and what was the new learning for you and what you want to learn from me in the next session? Please, quickly, just spend 2 more minutes. I would be glad and happy. If you don't like, you can say, I don't like. That's fine. I will improve myself. Don't worry. Don't sigh.
Sir, thank you so much as always for bringing such an
No, sir,
excellent
it's
session.
perfect.
One by one. Yes, yes, Sonia. So what's the new learning? I want to understand what's the new learning. You prepare by your
So,
own, and after listening, is there any change in your preparation that I want to research
yes,
and
sir.
understand?
Yes, sir, definitely, sir, because you bring a lot of clarity and insights as well. You give points which is can be actually practiced in a clinical setting also outside the exam pattern as well. And the
Wonderful,
charts which you provide concisely really helps us a lot for the exam so that we can recall during that time. So very helpful. So thank you so much.
wonderful, brilliant. Thank you very much. Yes, anyone, Rabia, yeah, you were.
Really, sir, your charts are brilliant. Yeah, really, sir, your charts are very good to recall questions
Thank you very much. I do a lot
for
of hard work
exams.
before session to collect the chart.
The source you are giving,
No
it's very
doubt, no
useful,
doubt.
sir.
Sorry, doctor.
The
Excellent,
source
sir.
you are the source you are providing is very useful, sir, to apply for the normal patients in our daily routine care.
Wonderful. Yeah, this is
No
how
doubt,
because
no doubt.
I am also a hardcore clinician for more than 2 decades, so I see hundreds of patients every day. So I try to club up my clinical knowledge with this exams as well. So probably that makes it more interesting because I'm
Yeah.
facing the same problem. The way you are facing, I'm facing same, right? So anyway, but I think I'm enjoying. You must be enjoying. Anyone else?
Excellent, sir. The concepts get clearer and clearer, and so much of hand holding. Actually, the pressure is on us now. How harder we can study now.
No, no, I'm not here to disappoint you, but I'm just trying to give you the real insight of the MCQs, how you supposed to prepare. See, I'm
Yes,
not saying in that sense, but nobody will put so much of hard and sincere efforts every Sunday 2 hours just to
yeah,
make you the clarity. I'm not preparing for any exam. I'm not preparing,
yes,
but
yes,
probably my expertise will help thousands of students. That is why I'm doing and pushing hard. And it's a passion for me. It's not a compulsion
yes,
for me. It's a passion for me. Coaching that you can little show it in my presentation every time. Anyway,
yes, sir.
anyone last who has joined the first time? I don't know. We have still 25 doctors. Anyone last want to make any comment or suggestions or advice? Everything is open. Yes, Saranya, any comment? Nas, Muhammad
Thank
Islam.
you so much, sir, for this wonderful elaborated class, which we could understand. You cleared each and every concept, you broke down and made it very concise, and made excellent tables that could be put everything together in one place. So we could just have them in one glance. So it means a lot. And thank you so much for all your efforts and hard work put into this to
My
make
pleasure.
our lives much easier. Thank you so much, sir. Excellent class as usual.
Thank you and for your motivating word.
Yes,
Great.
sir,
Yes,
this is
Pooja.
excellent class, sir. The way you precisely dissect every other options in the MCQ is very useful and clear for me and everyone, sir. Very nice class. Thank you, sir.
Great, wonderful. So go, we have more than 150 class on the air on the website. So just keep in touch. Thank you very
Yes.
much once again for joining and stay tuned. And I'll announce the next class as well. I want one more things, like probably I'm planning for one exclusive hematology because I'm getting a lot of requests that there is confusing one Willebrand and this and that, and there are a lot of things, leukemias, acute, chronic, lymphomas and all. So you tell me what exactly you want. So I cover that topic rather than I select my things. I know, I mean, what are the confusing to you in general, but if you can provide me, sir, okay, acute versus chronic leukemia, one topic or differential diagnosis of ITP or low platelet like ITP, septicemia, DIC, von Willebrand factor, or leukemia. How you differentiate in all C? All everybody has low platelet. Like that only. So you post me. This is my direct number 98255. So whatever the more inquiries will be generated, I'll touch that part so you learn more and you clarify the concept. Without concept, it's difficult to crack the exam. Believe me, in concepts are clear, forget about any questions, you will pass easily because you know the basic. Na? You give me any platelet, low platelet, give me, I'll solve in 5 minutes. Why? Because I know leukemia, what happens to platelet, WBC, hemoglobin, lymphoma, what happens, myeloma, what happens, ITP, what happens, DIC, what happens. I know, I have a clarity, right? So the likewise, I want you to learn and understand. So you post me, so I'll design accordingly my PowerPoint in the next time. Right. So thank you very much and enjoy your Sunday. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.